I'm Rachel Wall with Inspired Hygiene. I want to welcome you to this video training series. And what I'd like to talk with you about right now are the 3 P's of successful periodontal enrollment. Okay. So you know, if you've watched our previous videos, that you must first develop the conviction and calibration for your team before you ever get to this point. So I invite you to watch that video first if you haven't already. But the 3 P's, this is what we do before we ever pick up a scaler. So you may have heard me talk about the ultimate hygiene exam. This is what happens the moment the patient sits down in your chair. Obviously, we're greeting them and we're just kind of getting reconnected with them, finding those commonalities. But very quickly in that hygiene exam, we're starting to analyze their medical history, find out what has changed with them, what medications are you taking, what things might affect their oral health. And also we're looking at blood pressure, oral cancer exam, caries exam. All of these things that we do as part of our hygiene exam must occur before we ever pick up a scaler. We don't know what the patient needs that day unless we do this collection of the data. So this is obviously the periodontal exam portion of that, and this really all occurs within about the first 15 to 20 minutes of the hygiene exam. So it takes a good portion. It takes about a third of the hygiene visit. So the first P is prepare. It is critical that we prepare our patients for the periodontal exam. And you may have heard before, you should call out the number so the patient hears that, and that is so true, so important. So it might sound something a little bit like this. Ms. Jones, what I'm going to do now is I'm going to do the periodontal exam. I'm going to be using a tool to measure the level of the gums and the bone around each of your teeth, and we record this in millimeters, and this gives us an idea if there are any signs of gum disease here. So you're going to hear me call it a lot of numbers. If you hear 1, 2, or 3, then that's normal and healthy. If you hear 4, 5, or 6 or something higher, then that indicates that there's infection in that area. And if you hear lots of areas of bleeding, that also indicates infection there. So we're communicating to the patient before we ever do the exam what they need to look out for. So then they know it is objective and it could go either way. So the next step is, preparation is really important. And then whether you are alone with the patient in your operatory or you have someone entering your numbers, it's important that you call these out loud, okay? If you happen to have an automated period charting system that calls it out for you, all the better, all the more objective. So whatever you use, just make sure the patient is hearing those numbers, okay? The next thing is to probe. Now, obviously, we know probing is kind of the foundation of the periodontal exam, but there's so much more that goes with it. What I find now, used to be I would go into offices and they might not be probing at all. Now, usually they're taking pocket depths, but what I find is a lot of teams are leaving out the bleeding points, and this is critical. So we must have the pocket depth, and we must record bleeding points. This is so important because this is the sign of active disease. And also, if we don't have the bleeding benchmark when they go through treatment, once we get them to their evaluation, we have nowhere to compare how well they have responded if we don't have any bleeding charted. They could have had 40 sites of bleeding, and today they have 2, but if we didn't record that, we have no way of indicating that. And that, again, creates that value for the treatment that you have delivered. Also, of course, with your periodontal charting, you want to record recession. Recession and pocket depths allow you to calculate the clinical attachment level. Now, almost all of the clinical software now, once you enter the pocket depth and the recession, it will calculate the clinical attachment level for you. All right? So the other thing we want to track is obviously mobility and furcation involvement. Okay, very important. These are obviously all the things included in a complete periodontal exam. If you do nothing else, I just strongly encourage you to do the pocket depths and the bleeding, and then add these other pieces as you can, okay? I really encourage folks to do a complete periodontal charting at least once a year, and then possibly record pocket depths and bleeding on the alternate visit. So it's really important that we have this information. This is the evidence that we need to present our findings and for the recommended treatment. All right, so the next one is present. So we've prepared the patient for what to hear. We have done the exam. And let's say they have several 5 millimeter bleeding pockets, and we notice there's some bone loss on the x-rays. They are diabetic. All of a sudden, we've created this whole picture of what's going on with them. The presentation is our chance to create the story for them, to deliver this to them, to bring in the findings and say, Ms. Jones, I know you heard that there were some 5s, and we're calling out those numbers in a lot of areas of bleeding, and I'm really concerned because that indicates infection in those areas. So I'm going to sit you up. We're going to talk about this. So sit the patient up, okay? It's really important that we're sitting knee to knee with them and we're communicating to them person to person. The other thing that I really like and I really value is to print the periodontal charting out. And I really love to have that printed out in color. Okay, print that out. As you're sitting there with them, you can indicate the areas with the highlighter or a marker or even just a pen where they have the infection, and you can share with them, is it beginning, moderate, advanced? Is it localized? Is it generalized? Where are the most critical areas? What are you going to recommend? And before you make your recommendation, I invite you to really pull in those risk factors. Do they have occlusal risk factors in these areas? Does it look like there's somewhere in those areas where we might need to do some equilibration or something to give them the best outcome? What about medical risk factors like the diabetes? How does that affect their outcome? How does it affect their risk for progression of the disease? How does the periodontal disease affect their diabetes? Bring all of that in, and also bring in that conviction that you've developed, that knowledge that you have gained about systemic and periodontal risk factors. And it has to come from your heart. That's where that conviction comes in. We must believe that what we're recommending to our patients is the absolute best care. So if you're adding things like bacterial testing or localized antibiotics or systemic antibiotics or lasers, whatever it is that you're bringing in, I encourage you, just develop that strong belief system in your treatment modalities and what you've seen it do for your patients, and bring that into the presentation. So these are the 3 P's: prepare, probe, present, for successful periodontal enrollment.